Hello, everyone, and welcome to Grand Rounds today. My name is Tom Fardin. I'm the chair of Grand Rounds, along with Leslie Crichton, who isn't here today as she's on holiday. Um, Today, we welcome back Professor Andy Evans, who's a professor of breast imaging in the radiology department here. Andy spoke at Grand Rounds a couple of years ago about his experiences in. Now, were you in the Gaza Strip or were you in the West Bank? I can't remember.
I was in Gaza, yeah.
Yeah, so experiences of being in Gaza, which is a fascinating talk, which is available on our YouTube if you want to search back and find it. Really fascinating talk about his experiences of a short period of time in Gaza. But he's back here today to talk about what's new in breast imaging. We were just talking before we started there about mammograms and breast screening and how we get started again with those sorts of things in a post-COVID world. I'm not sure if he's going to touch on those things, but what he is going to tell us about is the cutting edge of new breast imaging techniques. Andy, looking forward to it. Thanks very much.
Okay. Hello, everybody. Thank you for tuning in. What I'm going to be talking about really falls into four sections. Firstly, we'll look at what we're doing with mammography, and there's been 2 or 3 interesting advances, which I'll talk to you about. A bit about ultrasound, but that's mainly about using shear wave elastography. We'll then talk about predicting prognosis using imaging and preoperative biopsy. And then finally, we'll talk about one or two advances in biopsy. So the big thing that changed was when mammography went digital, which actually happened a lot later than the rest of radiology, mainly because the spatial resolution required for mammography is higher. But that happened about 10 years ago, and this allowed us to quantify things and to add new technology, which we couldn't do with film screen. One of the things that we can now quantify accurately is breast density. The mammogram you can see there has a completely fatty pattern. You can see that this is almost all fat. This is the pectoral muscle there. This lady has quite a lot of dense fibroglandular tissue. And this woman has completely fibroglandular breasts. And as you can imagine, seeing cancers in a dense breast is much more difficult than seeing cancers in a fatty breast. This is just, and the thing that makes you generally go from dense to fatty is to get older. The menopause doesn't make that much of a difference to breast density, but you start to gradually lose breast density from the age of about 18. But there is a lot of variation. You do get women 30 with fatty breasts, and you get women of 80 with dense breasts. And as we were saying, spotting the birdie in the tree is a lot easier once all the leaves have fallen off. That's been known for a long time, but what we have noticed recently is that breast density also increases your risk of breast cancer. So if you look at women who have the top quartile of breast density, they have a 5 times increased risk compared with those women in the bottom 10%. So there is a lot of interest now in using breast density as a risk factor. And that really comes into screening. I'm not going to talk about screening today because that's really a topic in itself. But the whole way screening is starting to move is to do personalized screening. So we do risk factors from your family history, from maybe SNPs from your blood, and breast density, stick all that together and screen you if you're at high risk, and maybe not even screen you at all if you're at low risk. Well, that's the plan. I don't think it's going to happen in the next, well, it might happen in 5 years' time, but it's not going to happen in the next few years. But an awful lot of research is being put into personalized screening. The first actual imaging technique we're going to talk about is tomosynthesis. And this is really a bit of a poor man's CT scan through the breast. The mammogram machine takes multiple images at different angles and then reconstructs slices. and this blurs out overlapping tissue. Let me just go back. This is a normal 2D mammogram in a woman who's got quite dense breasts, and you can't really see anything down there at all. This is a tomosynthesis slice of the same patient, and you can see that there's a spiculated mass there. So tomosynthesis can certainly identify cancers that you can't see on routine mammography. It can also reduce your recall rate if you have a very high recall rate like the Americans do, but it doesn't seem to affect recall rate in the UK or Europe. The bad thing about tomosynthesis is that currently it doubles the dose. That's probably not important if you're over 50, but if you're young, it may be important. What is more serious is that it mainly detects low-grade cancers, because what it can find is this speculation, this star shape. And most of these cancers are the grade 1 or grade 2. And what concerns me is that if you look at interval cancer rates after screening, which is women who've had a normal screening mammogram and then present with cancer in the next few years, tomosynthesis hasn't affected that at all, which to me means that we're probably just increasing overdiagnosis. So we're finding small, low-grade cancers that may not affect a woman's life, or certainly detecting them before they present symptomatically may not be very important. I'm a bit more enthusiastic about this. In fact, I'm very enthusiastic about this, which is contrast-enhanced spectral mammography. And this is essentially doing a mammogram after you've injected them with contrast. And it's the same contrast we'd use for a CT scan. And what we do is get a low energy image, which is an equivalent to a standard mammogram. And then at exactly the same time, we take a high energy image, which is just at the energy which is sensitive to the contrast. And then we take one image from the other, and this subtracts out all the breast density and leaves only lesions which are vascular. And as we all know, malignant lesions tend to be vascular compared with benign lesions and normal tissue. So here's an example. This is a mammogram of a woman with a large cancer, but it's virtually impossible to see on the standard mammogram. But if you subtract out all that dense breast tissue, a blind bat could diagnose what is going on there. Here's just, at the moment in Dundee, we're doing a head-to-head comparison of contrast-enhanced mammography with breast MRI. MRI is like the gold standard, but it's expensive and it's time-consuming, and it's fairly unpleasant lying prone for 20 minutes to half an hour. This is a 2D mammogram, and you can see here that there's a mass there which you'd hope to pick up on screening mammography. This is the tomosynthesis, which makes this mass stand out a bit more. But this is the contrast-enhanced mammogram, and you can see that there's a focus up here and there's another focus down there. And if we compare that with the MRI, it really matches very very well. Here's another case. The eagle-eyed among you may have noticed that this sticks out a bit from the back of the breast, but it's pretty similar to normal breast tissue. But that's the tomosynthesis, which looks pretty much the same. But on contrast-enhanced mammography, where you've got rid of that density, it shows up really well. And it looked exactly as it does on the MRI. Just another case. This sticks out here, but on the contrast, you can see that there are some extra foci around, and exactly the same on MRI. This is just a case of ductal carcinoma in situ with a normal mammogram, a normal tomosynthesis, and on the contrast-enhanced mammogram, all you can see is some pretty subtle non-mass enhancement at the bottom of the breast that correlated with the similar finding on MRI, and that was a case of ductal carcinoma in situ presenting with Paget's disease. So in summary of contrast mammography, it's similar sensitivity to MR. It's probably a bit more specific in that MRI throws at quite a lot of false positives. It's faster, it's cheaper, and you can do it in the clinic rather than having to book it for a few weeks' time. And with one of our research staff has recently done a patient acceptability comparison with MR, and patients prefer it to MRI, despite you having to have compression, where with MR you don't have compression. The next thing we're going to mention is shear wave elastography, which is pretty standard on most new ultrasound machines now. And what shear wave elastography does is the ultrasound probe creates shear waves that go through the tissue, and ultra-fast sequences measure how fast these shear waves go through the tissue. And this creates a map. And sound goes through stiff tissue faster than it does through soft. And in general, cancers are stiff and benign lesions are soft. So this is what a cancer looks like. This is the grayscale image at the bottom here. And this is a color map of stiffness, where blue is soft, yellow is a bit stiff, and red is very stiff. You also get quantitative information. So we move this little circle, this region of interest circle around. And here you can read off in kilopascals the stiffness of the lesion. Normal tissue, whether it's fat or whether it's dense breast tissue, is not stiff. And this is a fibroadenoma, which, as you can see, is not stiff. How reproducible is it? Well, this is a study where I went and took 4 images, and a radiographer who does ultrasound did the same. And the intra-class correlation coefficient is extremely good. So it's reproducible and it's quantitative, both of which are obviously important. Well, what are we actually looking at? Well, we're not actually looking really at the cancer cells. We're actually looking at the collagen that is associated with benign and malignant lesions. Collagen in normal tissue and in fibroadenomas is well ordered and has relatively few crosslinks. So that's what collagen looks like down an electron microscope in normal tissue. Now, if you look at collagen in a cancer, the collagen looks like a dog's dinner. It is completely disorganized. The fibrils are a bit bigger, but the main thing is they have lots of crosslinks, and this is what causes the stiffness. The interesting thing is that the cancer-associated fibroblasts that make the collagen are not only within the tumor, but they surround the tumor for a number of millimeters, and this allows neoangiogenesis and invasion to take place. So the sort of bread and butter use of shear wave elastography is to tell benign from malignant lumps. And there have been over 30 studies, many from South Korea. They seem to love shear wave elastography, and they all show the same thing. That essentially, if you look at shear wave elastography alone, it has a similar performance to grayscale ultrasound. But if you put the two together, you get a higher performance. This is the study we did in Dundee back in 2012, and blue is this. Sorry, the BIRAD thing is. I'm trying to move my cursor without moving the slides on. So this is how grayscale ultrasound does with sensitivity. This is shear wave elastography, and if you only count it as benign, if both are negative, we got 100% sensitivity. We repeated that study in almost 1,000 solid breast masses in the symptomatic clinic and had a very similar finding. So what we now do with the first unit in the UK to change our policy, where if you present with what looks like a fibroadenoma and you're under 40, if it looks benign on shear wave and it looks benign on ultrasound, you don't get a core biopsy. You just get patted on the head and sent away, rejoicing. And this saves radiologist time, pathologist time, MDT time, and it also prevents women worrying about their result. We've audited and published our results from this change in policy, and we haven't missed any cancers in 2 years so far. What else can we use shear wave elastography for? It's actually pretty good at monitoring cancers who are being given neoadjuvant chemotherapy and predicting prognosis, and also predicting invasion when we get a biopsy result of in situ disease only. This is a study we looked at back in 2017, where we imaged women halfway through their chemotherapy to try and predict what the pathology result would be. And if you look at change in MRI diameter, the area under the curve is a respectable 0.68. If you looked at reduction in size on ultrasound, it was 0.67, almost identical. And when we looked at change in stiffness, the area under the curve was 0.82, which was significantly better. And I think if you're looking for early change on chemotherapy, you're always going to be onto a winner if you're looking at a functional thing like stiffness, rather than just looking at whether the tumor shrinks. The other interesting thing about shear wave elastography is that it varies with the pathology of the tumor. So it's stiffer in big tumors, but it's also stiffer in high-grade tumors compared with low-grade tumors. It's also an independent predictor of nodal involvement. So if you have the same size, the same grade of breast cancer, one is stiff and the other isn't, the nodal rate will be higher in those with nodal, in those who are stiff. It's also associated with vascular invasion. And we have documented, it's not a strong correlation, but it's a significant correlation of stiffness and resistance to chemotherapy. So given all that, it's not surprising that stiffness is actually a predictor of outcome in breast cancer patients. And you can see on this graph that if you're in the top, if you're in the least third, the lowest third of stiffness, your outcome is obviously significantly better than the other two groups. And this led us to the idea of looking at preoperative prediction of prognosis. We tend to give a lot more women systemic therapy, whether it's hormone therapy or whether it's chemotherapy, prior to surgery. But you certainly wouldn't want to give chemotherapy to someone who wouldn't end up getting chemotherapy post-operatively if you went down that path. And at the moment, there's no obvious way of predicting. I mean, people look at the size of the tumor, whether we've got an ultrasound-guided biopsy of a lymph node involvement or what the grade is on the core, but no one has stuck that all together to come up with a scientific way of predicting. So we have looked at a group of over 1,000 patients back from 2010 to 2015, with a mean follow-up of 6 years and 123 breast cancer deaths. So there are some obvious things that you would expect. So ultrasound size, highly predictive of death. But there are a few things you wouldn't expect, and we have only recently found out, which is if you look at the ultrasound scan of women with breast cancer, if you see this, which is the tissue behind the cancer is enhancing rather than being attenuated, that this gives you a significantly worse prognosis. And this is probably due to the cellularity of the tumor, but we're not sure. The other thing we've noticed is that on ultrasound, let me just go back. Yeah, on ultrasound, we often find that the skin is thickened. If you look here, this is the skin, and this should be less than 2.5 millimeters. Now, if the skin is grossly involved, you get peau d'orange and they're diagnosed with an inflammatory cancer. But 9 times out of 10, these women haven't got clinical skin involvement, but we can see either skin thickening or skin invasion on ultrasound. And you can see that there's a huge difference in the survival of women with breast cancer according to whether they have skin changes or not. And the main thing that's affecting it is skin thickening rather than skin invasion, as you can see from that Kaplan-Meier curve there. And as we said, it's only a relatively small percentage who have any clinical skin involvement, let alone inflammatory breast cancer, which is a clinical diagnosis. And over 3/4 of the deaths in the skin thickening group occurred in women who did not have clinical skin involvement. And we think it's to do with the lymphovascular plexus that's right and under the skin. And we think that you get tumor emboli within this, which cause edema of the skin. And the other thing that we can see that affects outcome is a preoperative diagnosis of nodal metastasis. And this is where we scan the axilla, find a thickened node, and do a core biopsy. Now, we only actually diagnose about 50% of women who are node positive using this, because we only detect those with a high nodal burden. And what we've done recently is compare the outcome for women who are node negative versus those who are ultrasound negative but had a positive sentinel node at surgery, and when we've made a preoperative diagnosis. And you can see from this graph here, this is node negative. This is having a positive sentinel node biopsy, and this is having a preoperative diagnosis with core biopsy. And you can see that the positive SNB outcomes are actually closer to the node negatives than they are to the preoperative diagnosis of nodal metastasis. So we certainly seem to be picking out the women with a poor outcome in those who have a preoperative diagnosis of nodal involvement. There's a strange fact when you look at predicting outcomes in breast cancer as to whether they're detected at screening or symptomatically. Now, you may say, well, that's not a surprise. At screening, you find them smaller and at a lower grade with less nodal involvement, but that's true. But if you do a multivariate analysis and you correct for grade, you forget for vascular invasion, you correct for size, nodal involvement, the whole works, there is still a difference, and we don't know why. So how your cancer is detected, irrespective of the pathology and of all the time-dependent prognostic factors, it's worse if you're symptomatic and better if you're screening. Core biopsy grade is reasonably accurate, but we do tend to find that we upgrade quite a lot of the grade 2 tumors to grade 3 when we take them out. But it's still highly predictive of outcome, as you can see. HER2 status, despite Herceptin being widely available for a number of years, it's still bad news to be HER2 positive. Whether we're now getting second generation HER2 agents, and whether that will make a difference, I don't know. And obviously ER status is an important prognostic as well as a predictive factor in breast cancer. The other strange thing that I didn't know till I started working on this was looking at comorbidities. We find that more women die of something else than die of breast cancer if they get breast cancer. And we have recently found that renal impairment, just by having a GFR that's not within the normal range, means that you're not only more likely to die of other things, but you're more likely to die of your breast cancer, and that's independent of pathology. So Professor Donnan and Huan Wang have recently taken all this data and come up with a predictive model. And you can see here a time-dependent area under the curve that comes from all this data. And you can see that we're getting an area under the curve of, for the first 4 years, of about 0.9, which is pretty spectacular. And even at 6 years, it's still above 0.8. Now, if you compare that with predict, and predict is the tool that every MDT uses after surgery. So this is after you've got a surgical specimen that predicts outcome 0.86. To be fair, we need to validate it on an independent set. There's obviously internal validation by bootstrapping on the data I've shown you, but certainly this looks like a very promising tool. Apart from it can't be that promising because I've just had the paper bounced by Lancet Oncology, but we will see. The last thing I'm going to talk to you about is biopsy, and most of the time we use core biopsy, which the downside of core biopsy is that between each sample you have to take the gun out, take the sample out, cock it and put it back in the patient. The good thing about vacuum biopsy is it's a bit of a vacuum cleaner. So you can see, let me just find my cursor. So there are these little holes in the needle which allow us to apply suction, and that suction sucks the tissue into the needle and then actually propels it out of the needle into a little basket. Now, if you compare, these are the different sample sizes. So these are what you get from a core biopsy. This is what the next one is what you get from when we do a diagnostic VAB, which is about an 11 gauge needle. And this is what we get when we use a 7 gauge vacuum assisted biopsy. And we use this to actually remove lesions rather than just sample them. So we routinely use the vacuum biopsy to biopsy calcifications in the breast because they're really hard to biopsy with core biopsy. We can use it to remove palpable lumps just because patients don't like having a fibroadenoma, but that's stopped due to COVID. And the more important thing is we use it to remove lesions which are benign but have some malignant potential. And these are papillomas and radial scars. So in themselves, they're benign, but if you leave them in the breast, they are associated with an increased risk of cancer in the future. We did some follow-up questionnaires on women who've had their fibroadenoma sucked out with our vacuum biopsy device. And you can see that the responses are very good. But there's some possible new indications for the use of vacuum biopsy. One is removing the tumor bed after you've got a complete response to neoadjuvant chemotherapy. The surgeons always get a bit hacked off when they've taken out a large area of breast tissue and there's no tumor left there at all. And so the idea has come around over the last few years of, if we actually remove the decent part of the tumor bed with the vacuum biopsy, could we actually avoid surgery in some of these cases? The other thing we're thinking about is removing tubular cancers with it, because they're pretty much a non-cancer. To use vacuum to look at the tumor bed, you need to know how good your end of treatment imaging is at predicting whether there's a complete response. And if you look at the diagnostic accuracies here, you can see that if you combine ultrasound and shear wave, or you do MRI, you're getting pretty accurate end of treatment prediction of response. And this is particularly true if you've got high-grade tumors, so either HER2 positive or triple negative tumors. It's not quite so good in the slower growing luminal cancers, but they tend to get less pre-op chemotherapy anyway. So there's a couple of studies, multi-center studies, that are starting up on this. The next is invasive tubular cancers. These are pretty uncommon cancers, probably about 5%, but we find them at screening. And unfortunately, they get treated like every other cancer at the moment. And this is despite no one that I know of has ever died of a tubular cancer. You only die of, if you've had a tubular cancer, if you get another more aggressive cancer. The prognosis is miles better than other grade 1 cancers. And if you look at their Oncotype DX score, which is really a score we use to predict outcome by looking at a number of molecular markers, you can see that tubular cancer's average score is extremely low. So I personally think, and other people are coming around to the idea that maybe we could just remove these with the vacuum biopsy, and it's unlikely they need radiotherapy or endocrine therapy afterwards, as their course is so indolent. So I'd like to thank all the people who've done most of the work on what I've just shown you. And that's a nice male bullfinch I saw 2 weeks ago. But thank you for your attention.
Andy, thanks very much for that. It's really fascinating stuff. And although strictly, I suppose, breast disease is above the diaphragm, it's out with the thorax. So it's certainly interesting to me. And I always find the grand rounds that are far away from my own speciality the most interesting, because my recollection of breast cancer is what I learned at medical school. And I think it's so easy to become detached from the advances that happen out with our own speciality. So I find that really fascinating. So thank you very much.
It's a pleasure.
I'm interested in the screening question of whether breast cancer screening does more good than harm or more harm than good, and particularly over the lockdown when screening necessarily came to a bit of a halt. When people asked me, I said that the best thing to do is regularly self-check. So you're screening yourself every day in the shower rather than relying on a once-a-year mammogram. But the data you showed there was that actually if you're detected by being symptomatic, you do worse than if you pick it by screening.
Yeah.
Was I telling people duff information, or?
Well, I think that.
Does it depend what you mean by symptomatic?
To be fair, I think there's been lots of stuff in the press which has been misleading. I think what people didn't do in the past was tell people what the downside of screening is. But some people have then taken that as meaning that it doesn't work. And the answer, I mean, it definitely does work in the age group of 40 to 70. You get a reduction in the population is about 25%. If you do case control studies of women who attend every screening invite, their particular risk goes down by about 50% of dying of breast cancer. However, there is the downside, and the two downsides are false positives, in that only about 1 in 10 of the women we recall have got cancer, and the other is overdiagnosis. And people get the wrong impression of what overdiagnosis is. They are real cancers, but they're just too indolent to do you any harm. It's not as bad as prostate cancer screening, which is about 60% overdiagnosis. So people are getting incontinent and not being able to have a sex life for cancers that would never do them any harm. But it does mean that about, in my estimation, between 10 and 15% of women are overdiagnosed through screening. The other is screening women over 70. This was introduced just to be politically correct. But you've got the double whammy of a shorter life expectancy, and also breast cancers become more indolent the older you get. So the overdiagnosis rate in women over 70 is huge. Also, there is absolutely zero RCT evidence of reducing breast cancer mortality in women over 70. There is a trial going on in the UK, which may actually give us some stuff on that in the future. But that trial only came about because the government introduced it, said we're going to screen everyone over 70. We all jumped up and down and said, why? Oh, because it works. And we said, no, it doesn't. And then so they fudged out by coming up with this age extension trial. No, screening works, but there are downsides, and it only works in certain age groups.
But self-examination remains an important part of proceedings, one presumes.
Well, you'd think it would, but the scientific evidence is not there.
Right. Okay, that's very interesting.
There's been a number of randomized controlled trials in Russia and in India of teaching women breast self-examination versus not teaching them, and the mortality rates are exactly the same. So that is counterintuitive, but unfortunately, science does come up with things that don't fit. So if it makes sense to examine yourself, of course it does, but is there hard scientific evidence to show that it works? Then I'm afraid that actually doesn't exist.
Right. Still turn up for your mammogram. Important stuff.
Yeah.
There's a few questions in the chat, 3 now. The first one is from Frank Carey, who says, in some other cancer types, e.g. colorectal, subtypes can similarly be defined into stroma-rich and stroma-poor. The latter group tends to be of an inflammatory phenotype and respond to immunomodulatory treatment, such as PD-L1 inhibitors. Does this apply in breast? So can you differentiate what the response is going to be by the imaging?
You can certainly differentiate. We've shown that there are quite a number of radiological factors that predict response to neoadjuvant chemotherapy. That's true. In actual fact, I think with Alessio, I see is with us. We've actually just recently started measuring PD-L1, but I'm not exactly sure of the details. Alessio, could you help me out on that? No.
He's shaking his head.
I'm sorry, but I can't. To be absolutely honest, no, I can't.
No. So there certainly has been a lot of work on inflammation and prognosis, but some of that work in breast cancer, some people say it's very important and other people say it's not. So I think there's probably some more detailed work to be done on that.
Okay, Wendy McMullen, previously of this parish and still a Grand Round regular, says, very interesting talk, thank you. Can pre-NACT score, e.g. with SWE, be used to plan, e.g. upscale NACT, in order to improve the prognosis in the very high-risk cancers?
Well, I don't know. I'm not an oncologist, but it's an interesting thought. Whether you would upscale it or whether you would downscale it, for those who are not at that high risk, I'm not sure. Maybe Wendy can put me wrong, but I was gobsmacked when I heard how you work out what dose to give in oncology, and I was told that it's essentially the highest dose where the patients don't die, rather than the lowest dose where the chemotherapy works.
Mm-hmm.
But I don't know if Wendy would tell me I'm completely wrong there, or whether there's an element of truth in that.
Well, I'm not an oncologist, Andy. I'm a surgeon, so I don't know. I mean, obviously, there's been a lot of politics recently about chemo for breast cancer, so it's slightly a sensitive territory. But yeah, it's just you're just thinking from the patient's point of view. If you're doing this massive score at the beginning and you know you've got the bad prognosis, it's very difficult to say to a patient, well, you've got a really bad prognosis. I mean, I know you don't say this, but you know, you're thinking you've got a really bad prognosis, but is there anything I can do with that information, or do they just get bog standard treatment? Knowing, you know, if you could say to the patient, well, we've got a bad prognosis and therefore we're going to hit you really hard with the chemo, that would be a really useful thing, wouldn't it?
I think it would. I think I have a feeling that many of our chemotherapy regimes in breast cancer are actually, some of them may be too aggressive, in that there's a budding. I went to a conference where there was a whole session on giving chemotherapy to the elderly, and many of our patients are older, and we're only just starting to do trials on reduced doses in more frail patients. And the response rates were remarkably good. They were virtually always the same as having the higher dose, but with a lower frequency of side effects. So I'm not sure. It may be that in certain selected groups, like maybe the HER2 positives, you should get second generation HER2 treatment rather than first generation. Alessio may have a comment on that.
Yeah, let's also consider about ladies who may have a luminal A cancer. So it's even weakly estrogen receptor positive, progesterone receptor positive. It's very difficult to notice a difference in terms of overall survival in those ladies, because most of that will actually come from the endocrine treatment that they are going to get. So in terms of science, sometimes it's very difficult to notice a statistically significant difference because there is not much. So, but I understand your concern about what you were saying, that sometimes we are giving too much chemotherapy. Yeah, I agree.
Yeah, I think there are some centres where there are hawks, and sometimes centres where there are doves concerning preoperative chemo. The oncologists here would never give chemo unless they were absolutely sure that if you did an immediate operation, they would get chemo afterwards. But I think there are some centres where they're more hawkish, and maybe what you're suggesting would make more sense.
Thanks very much.
Interesting.
Kevin McConville has a question. I think he'd like to say it in person.
Yeah, thanks, Tom. It's just easier than writing.
Absolutely.
It was a really useful talk again. Thank you. And it's good to kind of keep up to date with what's going on. It's just a question, comment, and it's not a criticism anyway. I know we're all really busy at the moment. The most local communication to general practice from the LNC letting us know that at the moment, if we refer on to the breast clinic for something urgent, the waiting time is 15 weeks, with an urgent suspected cancer referral sitting at 4 weeks. And I'm just wondering, is there anything we can do in general practice to try and help? You know, my experiences of the breast clinic is it's been fantastic with a kind of a one-stop shop, but if the patients are waiting, you know, is there anything we can do to help by, you know, asking for radiology images in between or not, or just where our thoughts are within that? Because it's obviously a worry for the patients when they've been told, yeah, we think it might be breast cancer, but you've got 4 weeks to wait to be seen at least.
I think there have been essentially two issues. One is when we had COVID, we were only allowed to see so many patients in the clinic because of social distancing. And then there's been a complete exodus of radiologists, which I'm hoping has nothing to do with me. But I'm currently the only permanent consultant breast radiologist in the whole of Tayside. We have some locums, but obviously they don't take the responsibility. And we've got a new manager who has finally been given some resources to try and improve the situation. But if I can be completely frank, she has been banging her head against the wall of the higher management of this hospital for months about this oncoming situation, and has been ignored for many months. And it's only now it's in the courier that we are finally getting the help we need. And so in my personal opinion, much of this could have been avoided. There is now a plan to get the waiting list down. I'm not sure there is a lot people in general practice can do to help us, apart from try and avoid not referring stuff that doesn't need referring, such as breast pains. Although I understand that if a patient cannot be reassured by their GP, they feel they have to refer them. But breast pain probably makes a quarter of our patients, and it is a bit of a waste of time.
Thanks. That's interesting to know. I wasn't aware of that. Maybe if we can feed that back even to the GP community, we can try and help with some of that for you. Thank you.
Yes, please. Thank you.
It's, if breast pain is a thing of which you can offer, then it's not useful for you to see. Perhaps that's something that can be pushed ahead with the LMC or an MCN type situation. And
yeah, I think
Alessio,
yeah, I think it would. Alessio, I think, would like to come in on that.
Yeah, please.
Yeah, I'm one of the breast surgeons, actually. Sorry, I've not introduced myself. Andy simply said I'm Alessio, but I didn't introduce myself. So yes, I can understand how difficult it is actually to manage in the community women who are worried and they want to be referred because there may be something going on. So I really appreciate the frustration, not only from the patient, coming from the patient, but from our colleagues in the community. In regards actually of the breast pain, we have set up a separate clinic, which is currently runs in Stracathro Hospital, which sees, one of my colleagues, Ms. McCaskill, sees all the patients referred for just breast pain with no lumps or any other suspicious findings. So those patients are seen there, and usually with a waiting time, which is actually way better than the other patients who need a one-stop appointment. We have, as Andy mentioned, our new manager has done a fantastic job, and I think we should all praise her because she has really tried hard to sort things out. And we have seen any improvement in the last few weeks. Actually, our capacity in terms of one-stop patients has improved in the last month. I think Andy can confirm that. So we have been seeing more patients, at least 40-50% more than we did even 2 months ago. So that there's been improvement. I'm not totally sure that the target that we have put out there will be respected because of multiple issues, some of them which are out of our control, mine and Andy's, and but we are trying to do as much as we can. I appreciate the question from the colleague that you're asking what can be done in the community. To be absolutely honest, there is very little that you can do, and we appreciate your collaboration. I just want to reassure, we have taken some action in the last few weeks. Things are getting better. We are trying to do our best. We are using PRI better. So we are seeing some patients who don't need to come physically to the skinny unit. They are being seen in a different area. So in terms of social distancing, there is more space, so we can accommodate more patients. We have done that. We are trying to explore all the options. Some things have improved, some others have not, but we are trying our best, and hopefully our waiting time will go back to normal soon, even though we can't really tell when that is going to happen.
Okay, thanks very much. So I don't think there's any more questions. So that just remains me to thank Andy for a really fascinating talk. Andy is a twin, and I know his twin before I met Andy. Because Simon is a chest physician. So when Andy appeared a few years ago, well, quite a few years ago now, and I'd see him, I'd just walk past and say hello, Simon, and we'd have I'd had to kick myself. But I think now if I saw Simon, I'd call him Andy. So I think the flipped around now. So anyway, I hope Simon's well. I've not seen him for a long time. But Andy, thank you so much for the talk today. It's been fantastic.
That's a pleasure. Okay then, John. Bye, everybody.
Week, before you disappear, next week, Lizzie Gordon from the university is going to speak about developing an evidence-based intervention to support doctors' well-being and promote resilience during COVID-19. There you go, I said it, COVID. And COVID-19 related transitions and beyond. So they're going to talk about their research they did during the first and second waves of COVID to support doctors, but also other healthcare professionals. So if you're interested in that sort of thing, that's next week, same time, same place, same link. Thanks again, Andy.
Okay, bye.
Cheers.